Let's go, break it down, put it there, bring it on, step it up, right there, break it down, put it there, here we go, step it up, bring it on, let's go.
Hi everyone, good afternoon and welcome to the live stream of Studium Generale Eindhoven. It's been over a year now since all of our lives turned upside down and we are still very much in the middle of a pandemic, unfortunately. With today's speaker, Anja Schreijer, we're going to take a look on all that's happened so far and also discuss the lessons learned, because likely this will not be the last pandemic we will ever face. This lecture has been initiated today by student team Sensus, who organized the student competition on biosensors. And there she is. Next to me is Puk Stasse, who is in charge of the public relations for Sensus and who will first explain a little bit about what their organization is about and also why they were keen to address today's topic on outbreak management. Welcome, Puk.
Yes, thank you, Marle. Hi, everybody. My name is Puk and I'm part of the Sensus organization. Sensus is a student team from the TUE and we collaborated with Studium Generale to organize this very lecture. I will give you a quick introduction of what Sensus is. So the main goal of our student team is to stimulate innovation in the field of sensors for health. And we do this by organizing an international student competition on biosensors. This year, we challenge students to develop sensors for rapid detection of the influenza virus, to be better prepared for a possible next virus outbreak. Anja Schreijer will tell you more about everything that is involved with containing virus outbreaks. Okay, so the teams that participate in our competition need to make a biosensor. A biosensor is a small device that can measure a concentration of a certain molecule. A sample of the body, for example, blood or saliva, will be analyzed. And this analysis can personalize treatment. A good example of biosensors are blood glucose measuring devices for diabetes, pregnancy tests, and rapid tests, like those for COVID-19. So Sensus organizes a contest in September, where students from all over the world come to Eindhoven to compete for the best biosensor. And they also participate in additional programs, events, and workshops. Last year, in our online edition, 15 teams participated in Sensus, and the event was watched by over 15,000 people globally. And we, as the Sensus organization, are responsible for arranging everything that is needed. The theme, the awards, sleeping places, promotion, etc. In the next slide, you can see our Sensus team, and currently we are looking for new members to join Sensus to make such a great event happen again. So why should you join Sensus? Sensus means innovation and new challenges. Within our student team, you will develop skills that go far beyond your standard university program. You will learn to negotiate with companies, you will communicate with students from all over the world, and you will work on many other skills. You can set your own goals and focus on your development. And the best part is that you will work in a really fun team with around 25 other motivated students. If you're interested in joining our team and working on the future of healthcare, visit our website sensus.org/join to find out more and sign up. We also have a lunch lecture on the 23rd of April, where we will tell you more about Sensus and what we do. So please come if you're interested in joining our student team. But for now, I hope you will enjoy this lecture by Anja Schreijer. We are very happy that she's here to tell us more about the most relevant pandemic of the moment and about much more. So enjoy the lecture.
Okay, Puk, thank you very much. And let me also say that if you have any questions specifically to Sensus, they will also participate in the chat on YouTube and on Facebook. And as usual, this is also the place where you can ask all of your questions to today's speaker. Puk already mentioned Anja Schreijer, a medical doctor specialized in society and health, head of infectious disease control at the GGD, the Public Health Service in Amsterdam, and chair of the National Consultation on Infectious Disease Control. And in that capacity, she's also a member of the Outbreak Management Team that advises the Dutch government on the COVID-19 outbreak. We're very happy she can be with us today. Anja, welcome to the live stream. And the floor is yours. Please tell us all about how to handle the current crisis.
Yes, thank you, Marla. Thank you for your kind introduction. And also thank you for giving me the opportunity to tell you something more about this very exciting work in the field of infectious disease control that has normally been done behind the scenes, but is now, of course, in the spotlight. Okay, please, next slide. I will start, so this is the content of my presentation. I'll tell you a little bit about the history of infectious diseases, the governance, the basic principles, looking back at 1 year of COVID, and some lessons learned. Next slide, please. I think it's always very important that you understand the history of a topic once you dive into it. And it's good to know, and I think you all know, that infectious diseases have always existed, and bacteria and viruses have been on this planet much longer than we have. So already in the old ages, there was a big role for municipalities and city doctors, like doctors who work at the public health service, for preventing and alarming and also putting people in quarantine, and also for vaccination. On the left, you see an example of a plague doctor who's wearing a plague mask. And the mask was actually to keep away the bad smells, known as so-called miasma. And in those days, people thought that it was actually the smells that caused the disease. And that was, of course, before they knew, and scientists knew, that it was actually bacteria and viruses who caused diseases. In the middle, you see an example of a pest house, and I think this one is actually in Leiden. And that was a type of building that was used for persons who were afflicted with communicable diseases, such as in those days tuberculosis, cholera, smallpox, or typhus. And people were actually forced into quarantine in those days. And then you could either, of course, recover from the disease, chances were not too big, or you died of the disease. And many towns and cities also had a cemetery or a waste pond next to such pest houses for the disposal of the dead. Next slide, please. In the 20th century, there were some really big changes and also a few game changers in the outbreak management. And very simple, it started with hygiene and sanitation. People started to see when they wash their hands, for example, that had a great impact in the spread of infectious diseases. Of course, science played a big role in developing new medicines, like, for example, antibiotics, vaccinations, national campaigns, health insurance. There were several developments in the case of tuberculosis and sexual transmitted diseases. And last but not least, the first municipal public health service was established in Amsterdam in 1901. Next slide, please. Like I said, one of the big game changers was the invention of vaccination. And it's quite an interesting story because it was actually Dr. Jenner, who was an English physician who worked in the south of England, who found that milkmaids were not infected with the smallpox that often as other people were. And he found out that it was actually the infection by cowpox earlier by these so-called milkmaids that protected them from infection of smallpox. And that was the first step towards smallpox vaccine. So that observation was very important. And this is just a picture of the Rijksmuseum with a famous picture of Johannes Vermeer. At the left, March 2018. And at the right, October 2020, in a totally different world with my daughter. Next slide. And like I said, this was a real game changer. And eventually it was, it took until 1980 before the smallpox was totally eradicated from the world. And this was a big milestone in history. Next slide, please. Another milestone was the birth of field epidemiology. So at the left, you see a map of London around 1850. And at the right, you see a water pump. And in those days, there was a big epidemic of cholera. And what John Snow did was actually, sounds very logical now, but was actually quite inventive at that time. He began his investigation by determining where in the area persons with cholera lived and worked. And he marked these on a map. And he found out that these people worked and lived around a water pump. So he closed the water pump and found out that the amount of cases declined. And so that was the first step towards source control in the work that we do nowadays called source control and contact tracing. Next slide, please. So, and take you a few steps further in time. As you all know, we now have to deal with a lot of emerging infectious diseases. We live in a world where people can travel from one side of the world to the other side in only 24 hours. There's a big the overpopulation. People and animals live very closely to each other. And climate change, of course. And on this map, you see all the challenges that were reported in by 2018, I think this is, but there's already many more. Next slide, please. So how to deal with this worldwide? Next slide. So many countries and all the member states of the WHO at least found that they have a shared responsibility to protect the world from these outbreaks. And that's why in 2005, the international health regulations was a fact. And in this pact, all the member states promised that they will detect, assess, report, and respond to infectious diseases as quickly and as soon as possible as they can. But you can imagine that it's a different story in different places in the world. Next slide, please. So what is the case in the Netherlands then? Well, when there's an event of an infection, the OMT comes together, the Outbreak Management Team. It wasn't that famous before, but it was actually already like 20, 30 years ago that the first OMT came together. And so normally that only happens once a year or twice a year, but this year it happened, of course, many times. And the role of the OMT is not to decide on any measurements, but to advise policymakers who eventually advise the minister, who eventually takes the decision. So it's very good to understand that the OMT does not decide by itself, but advises the minister. Although some people think differently nowadays. Yeah. And also sometimes a veterinarian, so it depends on the infection, what kind of scientists are invited to join the OMT. There are a few structural members, but of course, you can imagine that if there's a disease that concerns, for example, zoonosis, which is transmissible from animal to humans, then you can also choose to invite a veterinarian, for example, etc. Next slide, please. Well, there's a whole list of notifiable diseases in the Netherlands. And it's good to know that both medical doctors, but also laboratories, are mandated to notify infectious diseases to the local public health service. So they can start their source and contract tracing. And in their turn, the Public Health Service reports to the National Health Institute, the RIVM, who notices if it's very important or very big or very unusual, will also report to the WHO or the European Centre of Disease Control. And that way we try to keep each other informed as soon as possible about new outbreaks. Next slide, please. Then something about the basic principles of infectious diseases. Next slide, please. I would like you to focus on the right side of figure 6, which shows the transmission flow chart. And that's just a way of thinking and makes it easy to how the transmission of infectious diseases go. So you have a reservoir, a source, there's an index, a first patient, and who has contacts, who infected other contacts. And time point A, B, and C are the moments for intervention. So, for example, elimination of the reservoir, the source, vaccination, the use or prescription of antibiotics, or measurements like nowadays isolation and quarantine, or even a lockdown that it wasn't actually in any guideline. Next slide. Another thing that is good to be aware of, that the incubation time for a disease causes a delayed detection of COVID infections. As you can see at the left, there's a moment of infection Then it takes a few days before patients get their first symptoms. Then it takes some time before they get tests and get the results. And then they either recover or they get hospitalized, which also is a few days later, and then are admitted to the intensive care or not, or even are deceased. And I think this is a good to be aware of this, because a lot of the times when new measurements are being decided upon by the government, we get immediately questions 2 days later: do they have any effect? Does the lockdown have an effect? Does the evening clock have an effect? And it takes some time to see the effect of these measurements back in the numbers, either the number of infections or the hospitalization numbers or the intensive care numbers. Next slide, please. This is also an important conceptual way of thinking. This is the conceptual pyramid of infectious persons. In the bottom of the pyramid are those who are infected but do not have any complaints, but might be infectious to other persons. And that is the biggest group that we didn't see in the start of the epidemic, and mostly do not see. Then there's a part of the population who has mild complaints. Sometimes they get tested. And then there's a part of the population with severe complaints who do normally get tested, because they go and see a physician, or they even go to the hospital. Next slide, please. Furthermore, it's important to realize that testing and tracing, contact tracing, are most effective when the timelines are short. And those timelines are different for every infection. So the incubation period can be different for several different viruses. So on this slide, you see an example of an index who later on gets complaints, who later on gets symptoms, and who in the meantime has infected another person, who in his or her turn also has infected another person. So if you put people into isolation at home, or put contacts into quarantine, you can prevent subsequent infections. And the sooner you do that, so the sooner you get tested, the sooner you're able of identifying people at risk, and the sooner you are able of breaking the chain of further subsequent infections. Next slide, please. And the other goal of testing of tracing is, of course, surveillance. And we want to know in the Netherlands, are the numbers going up? Are they going down? Are the measurements doing any good or not? But also, it helps us to identify clusters and settings of infections. For example, this is a slide that Jaap van Dissel used last week. And there he shows the data that they collected from all the public health services from their contract tracing. And there you can see that the most clusters, so that is a situation with 3 or more persons in one cluster, you can see the different settings. So the people are still affected mostly at home, or by their visitors, or at work. And that was different before the lockdown, of course. Next slide, please. Okay, so looking back at 1 year of COVID. Next slide. Well, I think we can all agree it was quite a roller coaster. From the first reports, I've put there a tweet of Marion Koopmans, first reports of Wuhan, first lockdown that has not been in any guideline book for outbreak management before, but we had to do that. The summer that we all think of now, that was had too much freedom because the numbers went up quickly in autumn. And last but not least, after the second wave, we started to vaccinate the first persons. Next slide. So this is also the lessons learned during the year. Of course, you all know that we had insufficient intensive care capacity. We had insufficient protection material. We had insufficient insufficient test capacity. Not only people, but also the materials there were not sufficient to deal with such a pandemic. And that was not a problem only in the Netherlands, but that was seen worldwide. We had insufficient source and contact investigators. We had to train these people in just a few weeks, which is work that has normally been done by only a few nurses. Like, for example, in Amsterdam, there's 2 to 3 nurses working every day on source and contact tracing, and now it's 200 to 300. And last but not least, we had a very few infectious disease control specialists. During the year, we had to cope with mutations and, of course, also with the loss of effect of the measurements, because also behavior is a very important factor in this. People are getting really fed up, of course, with all these measurements, and it's quite difficult to still follow these measurements, like for example, having only 1 visitor a day. Next slide, please. This is very important as well, because this slide shows the 2 waves in 2020, and it shows the effect that the upscaling of test capacity had, because this provided an improved view on the development of the pandemic. On the left, you see the reported cases versus the modeled number of new cases. And as you can see at the left, during the first wave, when there was not enough testing capacity, we only saw 8% of all the real cases that there actually were. Whereas in the second wave in autumn, it was almost up to 50% of the number of new cases that actually were reported. So it was both the testing capacity, but also the testing willingness that plays an important role here. Next slide, please. Yes, on this slide, you see the effect of measurements on the R and the number of infectious persons. And so I'll take you through this slide. The red one is the number of infectious persons. The gray line is the reproduction number, the so-called R, which illustrates the amount of people that are affected by one person. And the blue line is the stringency index for the measurements that's been taken. So, like, for example, the evening clock is a very stringent measurement, whereas meeting only with 10 people outside is a less stringent measurement. And as you can see, during 2020, there's a really important interplay between the reproduction number and the number of infectious persons. And if you look at July and August, the reproduction number was still very high, above 1. So, but there were not a lot of infectious persons. But in the meantime, because of the measurements were not stringent, the amount of infectious persons started to grow, and that caused the second wave. Next slide, please. Because there was a big reservoir, eventually, of infectious persons. Another thing we had to deal with, unfortunately, is the British variant, which is up to 34% more contagious compared to the wild type, and affects very much the reproduction number, as you all know. And it took only a few weeks before this variant became dominant, as you can see on the first graph. Next slide, please. Well, why can we not lift all the measurements now? It's nice weather. We all want to go outside now. We have to open the terraces, and what's the big deal? Why is that not a good idea? It's not a good idea because of the following figure. This is a prediction model that you might have seen. This is actually 3 scenarios. The blue scenario is we continue the measurements as we do now. The red scenario is we stop everything and go back to February 2020. Then we will see a big rise in people who will be admitted to the intensive care, and it will be too big for the hospitals to deal with. So the hospitals will be full, and the ICs will be full. So that's the reason why also the OMT advises the government not to let loose all the measurements now. Next slide, please. So what are the lessons learned so far? Well, I've shown you a lot of the bottlenecks that we had to deal with. It's either persons or materials, regarding testing, regarding hospital, the amount of people that can be admitted to the hospital or to the care homes, the way people deal with the measurements, new variants, and of course the vaccination. And although that is a bumpy road as well. The next key learning is that behavior is really the key to success of all these things. You can invent and think of a lot of very innovative testing methods, but if people do not want to take the test or do not want to live up to all the tracing measurements that you ask them to do, like isolation or quarantine, things will not work. And the same goes for vaccination. If we can have all the vaccination and the best vaccines in the world, but people have to take them, otherwise it won't work. And if we think for COVID, at least 70% of the population needs to be vaccinated to stop further spreading of the disease. Next slide, please. We also know that, of course, collaboration with various parties is very important on a national, international, but also on a local level between professionals, policymakers, decision makers. And what we've also seen that modeling is quite important to predict the effect of certain measurements. We also know that if we do not test people, we cannot control the pandemic, because without testing, there's no surveillance and there's no control. And what we've also learned is that you have to be capable to do some scenario thinking, to look in the future and think about all the things that can happen, and also expect the unexpected, like, for example, new variants that can be even more easily transmitted or can cause more disease. Next slide, please. So the question to me was how to contain the next pandemic. And when I was preparing this presentation, one thing is that it's actually too early to draw a conclusion, but I do want to make a first attempt. And these are the bullets that are important for a next pandemic. First of all, international cooperation, a global approach in the case of testing, buying materials for testing, training of professionals for testing, invention of new tests. Also, this goes for vaccination, so an evenly spread of vaccines during over the whole world. We have to increase the capacity of testing and tracing. We have to create an overcapacity of infectious disease professionals, both doctors and nurses, but also epidemiologists. And here's a challenge for you, I think, to invest in but also think of new innovative testing, which are scalable. So you have to be able to scale up very quickly. And they also have to be accessible. So we have to make it easy for people to get tested. So like, for example, the self-testing that's been introduced now. We also have to think about our testing strategy. Now we're testing everybody as much as possible, but later on we might focus more on the hard to reach risk groups. And we actually do that in Amsterdam already. We also have to be aware of the big role of behavior. And I think there's the role of behavioral science in management, outbreak management should be bigger. And we have to think of targeted interventions that are not thought of behind your computer, but are actually based on barriers and motivators to certain behavior by talking to certain risk groups. Then, of course, you can also think of new ways of vaccinations, for example, micro needle patches that have been invented earlier. That could be a very good way of tackling a next pandemic. And of course, the future role of artificial intelligence and robotic process automation, because a lot of the things we do is still human work, but I think a lot of the work that we do can be done by computers in the next pandemic. So thank you for your attention and giving me the opportunity to share these thoughts with you. And I hope it's a bit inspiring, but and also gives you some inspiration for your future work.
Okay, Anja, thank you very much. We asked you to kind of summarize the whole pandemic in 20 to 25 minutes.
Yeah.
So I would say job well done. At least that's quite a challenge already. Something that struck me that you mentioned was somewhere, I think midway during your talk, the lockdown wasn't in any guideline that you had envisioned beforehand.
True.
What was that the biggest surprise?
And it's the first thing that, I think so. And not only us, but I think many international experts agree on that. And lockdown wasn't in any guideline, and it wasn't something we had practiced ever before. We've been practicing outbreaks, of course, on many levels, but a lockdown was never part of the scenario.
Was the reason that we never envisioned it could get this serious, or?
Yes, I think so, because we always thought we could contain little outbreaks, and of course we knew it could get bigger, but we thought we would still be aware of containing it in an earlier stage. That's the one side of the coin. On the other side, we also knew that it was not a matter if we would have a pandemic, but when we would have a pandemic. So you could say we could have prepared that better, and we should definitely learn from this one.
So for now, it will be in the books for eternity that this is actually a real scenario. Or?
Well, I hope we can find a way and think of a way by evaluating this epidemic very well, not only in the Netherlands, but also with international experts, to think of ways that we can prevent lockdowns like these, because the social impact, as we all know, is far too big. And I hope we can find a way that we can prevent that in the future.
Right. I see we have a few questions already coming in the chat. Let me just have a brief look. Some are about testing. Maybe we can group those. How do you think we can achieve a better spread over the world of vaccinations is one question.
Yeah, that's a very good question, a very important question. That's why I also mention it in my summary. I think we should really evaluate the way vaccines were bought, but also you've seen that some countries who bought vaccines for themselves, like Israel, they paid just a little bit more money. So what's the role of governments? What's the role of the pharmaceutical companies themselves? I think they did a great job in speeding up all these several steps for like quite a new way of making vaccines with the mRNA methods. So that's really, really a big win. But I think we have to learn of the ways that we bought these vaccines, what we paid for them, and how we distributed them. Because people are right to see that we're complaining here in the Netherlands, but there are many countries in the world who don't even have access to vaccination as yet.
Exactly right. It is also said to increase inequality.
Definitely, it increases inequality, and that shouldn't be the case. And I think WHO will definitely make a point of that in their evaluation. I hope they will.
Okay, let me see. Regarding the testing, people are wondering if you think it's a good idea to give all 60 plus people the first shot. And I think this refers to a statement by Gommers and Kuipers in the news today. So I think it was to postpone the second shot and first get all 60 plus people the first shot.
Yeah, you said testing, but you meant vaccination. That's true. That's a very important point. And we've seen countries like the UK who are doing this. And I think, but in the Netherlands, we have the Health Council. And it's not a role of the Outbreak Management Team, but it's a role of the Health Council, who have been looking into that. And we're following the European medical, the EMA in this. And so you can postpone the second shot a little bit, but postponing it too long might also give certain new variants and even more deadlier variants or even more transmissible variants a way to escape. And then we have a bigger problem at the end. So I think we've seriously looked into that, but I do agree, and I've also mentioned that in several interviews, that the best thing we can do is to vaccinate as soon and as quickly as possible all the 60 people above 60 of age, because that's the only way we can prevent the pressure and take down the pressure that is on the hospitals and on the intensive care units now. Because if we prevent these groups, then we can prevent people getting, these are the most vulnerable groups, and by vaccinating them, you can prevent a lot of the disease. But it is a little bit of a lucky shot to just say, like, for example, Pfizer has said, it's definitely not a good idea to postpone the second shot. Whereas for AstraZeneca, that's a different story. And for Janssen, there's only one shot. So that's a different story for every different vaccine. And we also have to trust on what the industry tells us in that way.
I can imagine it can be quite a difficult thing to balance between being thoroughly scientific and treating all the evidence in a responsible way, but also having to manage a crisis situation. I think that's what I've read about Diederik Gommers as well, that he said a crisis requires actually a different strategy where you have to take more risk.
Yeah, but at the moment, we are waiting for a lot of the vaccines, the delivery of vaccines. I mean, the public health service are ready. There are people who are sitting in all these public health services who are trained and ready to give all these shots, and they're actually getting a bit bored because there's not so many people there who are getting their vaccination at the moment. So it's a challenge, and I hope we will take that corner very quickly and speed up things.
Okay, thanks. There's a general question about the Outbreak Management Team. Who determines the goals criteria of outbreak management, and how are priorities determined?
I'm not sure I understand the questions. So the Outbreak Management Team can come together either because we think as scientists that we should, because there's something unusual going on somewhere in the world or in the Netherlands, and an unusual amount of disease. And then we come together and we, of course, decide what the goal should be. That's one way. What also can happen is that the Ministry of Health calls upon the RVM and says, I think it's now time to get the Outbreak Management Team together because there's something going on and I have a few questions and I need your advice. So that's two ways.
Maybe I'm not sure either what this person means, but I can imagine it's something about the priorities of, first we advise to keep the lockdown and then we meet more people or something along that line. Like, how do you prioritize which regulations to keep in place, for example?
Yeah, but what the Outbreak Management Management Team does is pure scientific. So we can only judge upon the risks that are there from a medical point of view. There are no behavioral scientists, for example. There are no economists, for example, in the outbreak management. And that's actually the role of the BAO that I showed you earlier, the policymakers, or maybe we should have a sort of impact management team in between the outbreak management team and the Ministry of Health, because they have the role of sort of waging the feasibility of all these advices that we give. Mm-hmm. But we really look at it from a medical, scientific-based point of view.
And would it be a good idea to add behavioral scientists to the OMT itself, or would you advocate
I think
for a separate?
Keep it separate. Yeah, mm-hmm. And I think the Ministry of Health already did a good thing because they have the OMT or the Outbreak Management Team is not the only advisor of the Ministry of Health. They also have economists and they also have behavioral scientists advising them.
Okay, thanks. Another question about the OMT is what are some long-term effects or focus points that the OMT is focusing on? For example, the possibility of the coronavirus and some mutations becoming endemic. So something that's just going to be part of our life permanently.
Yeah, To be fair, I wish we have been able to look more far in the future, but we have been focusing on the present a lot. And I'm sure we will do in the nearby future. But at the moment, there's so much uncertainties about, like you mentioned, certain variants of the virus, the variants of concerns that we see all around the world now developing now. Mm-hmm. So there's so much uncertainty now also about the fact whether the vaccines will actually protect against transmission. We don't know yet for sure. We think it does, but we don't know yet. So we can do a lot of modeling, but like you can see in all the presentations also of Jaap van Dissel, is when he goes to the members of parliament, is that there's a lot of uncertainties in all the prediction models. So we try to do our best, but we will not get rid of this virus. That's for sure. And I think it will be a sort of seasonal virus that will come back every year, just like the flu. But before that, we need to get the immunity levels much higher, either by vaccination or by people actually getting the disease.
Yeah, I can imagine it's quite hard to look back when you're still very much in the middle of the crisis itself.
Yeah, but I agree. We should do that, and we should take time for that, and not only us. I think we should do that on a more international level, like really trying to find out what are the possible scenarios, and like I mentioned before, expect the unexpected.
Right. Okay, I'm just briefly going to mention, because officially this is the end of the lecture. So for the youth students, if you would like to register, you will now find the link in the chat. Fortunately, we've already discussed with Anja that she's available for a little longer, and I still see some questions coming in. So we're just going to continue with the next question.
Are there any questions on testing or only vaccination?
Yeah, and so far it's I think there was one more about it has disappeared. Let's see. Just briefly going through them.
It's not a problem. I mean, you can just shoot.
This one is not about testing, but it is interesting. Looking at the civil unrest caused by some of the measures taken, would you argue that we should have a more public debate on the impact of the medical and ethical motivations underlying them?
Definitely, really agree on that. But it's a difficult thing to do that in the middle of a crisis. I think that is definitely something we have to do after this crisis, and we definitely have to find a way of giving the general public a voice during a crisis. And I'm not sure how we can do that, whether that has to that sort of a certain platform or something like that. But we really now miss a place where the public debate can take place, and that's why you see all these tweets or also sometimes very unpleasant media articles about the way the OMT is behaving or the Ministry of Health is behaving. Mm-hmm. And I can imagine that, because it's very frustrating and everybody wants their freedom back. But it's a very difficult situation where we are in now. And
because
I hope we can find a way to canalize that better.
We've had the Red Team for a while. That was sort of a criticaster of the OMT in some ways, at least in my view. I haven't heard from them in a while now. Were you in favor of having such a dynamic?
No, the Red Team is not really the voice of the population, I think. I really have respect for some of the analysis that they did, and some of them are definitely experts as well. But we cannot all be in the OMT because that will be too big. But I think this question is different, because we really have to find a way to more canalize the public debate. That's one side of the coin. And the other side of the coin is, when in a crisis, like in a war, you cannot please everybody.
Okay, thanks. I see a question.
And again, it's not the OMT who decides. It's the government who decides. We advise.
Yeah. So those in favor could argue we need politics to make a move on enabling more of this debate to take place in public spaces, for example.
Yeah.
Okay, we have a question about testing.
Okay.
If we would have had rapid tests at the start of the pandemic, how big a difference would this make in the development of the pandemic?
Yeah, as you can see in the figures that I showed before, I think it would have definitely made a difference if we could have tested everybody right from the start. You see that, for example, in Germany, they had a great testing capacity, whereas they were one of the first European countries where there was an introduction of the COVID virus. Mm-hmm. And by testing and tracing, they were able to quickly contain one of the first cases. But that's not only for the Netherlands, but that's one of the lessons learned, I think, is that we really have to increase the testing capacity. I cannot say that we would have been prepared then and the outbreak wouldn't have been that big, because there are so many factors that played a role, but it might have slowed down the spread of the infection, or the epidemic in the Netherlands a bit longer, at least.
Because I don't know if I remember correctly, but I think in Wuhan, in China, they were rather quick to take up the testing and the quarantine, and perhaps more so than Europe.
It's a different culture as well. I mean, mm-hmm. I have also people asking me, well, why did we skip Carnival last year? And if you think of these kind of measures, even before there was only one case in the Netherlands, I don't think the general population was ready for such stringent measurements already then. So it's quite difficult to imagine the world we lived in then, and the kind of risk that we sort of felt that was actually there. So risk communication is a very important thing. I think now we've all experienced what it is like to deal with such a big pandemic, and what kind of stringent measurements are actually sometimes needed to take to prevent that the hospitals are overloaded. We might be able to easily or earlier contain, both with testing and also with tracing, and also by, for example, isolating certain maybe places for a little while. But I don't think in the beginning of 2020 the Netherlands would have been ready for such a way of really how do you call it, forced isolation and quarantine like there was in China. I don't think that would have worked in the Netherlands with the kind of culture that we have.
Yeah, true. Another question about the self-test. I think it was in the news this morning that you can now buy them from some pharmacies and drugstores. What is your opinion about the self-test that people can now buy at home? Could this lead to a false sense of security?
False sense of security could be. Well, it's very important that you look at the guidelines when you buy a test, and you take the test in the right way. So there's two sides of it. On the one side, I'm very happy that people take that test when they go and visit their grandmother or their parents or whatsoever, and they want to make sure that they're not infected. But on the other side, it is still very important that you go to the public health service, to the GGD, when you either have complaints or when you have been in contact with somebody, and you can get a test, even if you don't have any symptoms, right after as soon as possible, and also on day 5 of the last contact. Those kind of tests should not be done by self-testing. That's a different population of people that still have to go to the GGD. But I think, self-testing can be a way of people giving more of feeling of security. But there is there is a risk of false negatives. Yeah. And the most important thing is that people do go and get a retest once they are tested positive, and go to the GGD. So we can do our source and contact tracing.
Right. Okay, maybe we can end with the person who asked the first question. which is about quite a different topic, but you discussed the effects of climate change on the likelihood of epidemics.
Oh, yeah.
Are there any inventive new scientific, between brackets, approaches for understanding and recording this effect into scientific knowledge, or how to incorporate that in research?
Oh, that's a very difficult question. Yeah, climate change has, there's so many effects of climate change, the way we behave. For example, what we see in certain areas is that by climate change, people and animals are getting more in contact with each other, or flooding of certain areas, whereby mosquitoes have a chance of getting who nest them in new countries, like for example in Italy, but also here in the Netherlands. We have mosquitoes now who actually can, for example, infect you with the West Nile virus. That wasn't the case for quite a long time. Malaria, also such an example. So there are so many aspects to climate change and the impact of infectious diseases and infectious disease control. It will take a whole new lecture to discuss that topic, I think.
Yeah, I can see that. Yeah, someone follows up on that also. Like, how do we prevent? How do we make sure that those things will be taken more seriously, perhaps, than we've anticipated this current pandemic?
Well, I hope we do a very good evaluation and look at this pandemic from all different sides of the pandemic. So from professional side, but also from the side of the general population, the impact that it had, the behavioral impact that it had, the impact that it had on the freedom of people. But also, I hope that people will think twice before they travel around the world and think about whether it's really necessary to go to that meeting on the other side of the world, or they can have a distance phone call instead. Is it really necessary to go on a holiday 4 times a year with an airplane, or is it also, I think a lot of people have experienced the beauty of the Netherlands in the last year. So I think we
quite
have to,
exhaustively, perhaps.
yeah, but people were also surprised by the beauty of it. So I think I hope that we can be a little bit more sensible with our behavior, but I'm not sure.
Right. Yeah, and maybe also there expect the unexpected more than ever.
The unexpected.
Okay. Anja, thanks again very much, also on behalf of Sensus, for your precious time to be with us here today. And also thank you at home for contributing with the very good questions. We wish you best of luck with handling the third wave as it is, and hopefully slowly transitioning towards the end of the pandemic.
I hope so too, and you good luck with all your future work.
Thank you. So
the future depends on you guys.
Yes, for all the students, I was just going to say, for all the students that feel inspired, perhaps why not join Sensus and come up with some good biosensors yourself. On the 23rd of April, they have their lecture to inform you about the Sensus competition. Studium Generale will be back tomorrow evening with a lecture about the World Press Photo Exhibition. And tomorrow you can also find our new program online to give you something to look forward to after the exams. But first, I suggest you go and find yourself a lovely place in the sun, nicely socially distanced, to enjoy the rest of the day. And we look forward to seeing you again next time. Bye.